Hello, everybody. Thank you so much for the chance to present my research here. My name is Baukje Lebouille. I'm a Dutch MD PhD student doing a research internship at CNO. And today I'd like to talk about an explorative study that I did together with students from the Technical University of Delft and Rotterdam in the last year. It's on a development of an automated segmentation algorithm in patients with rheuma. So that's what I'll be talking about. A little bit of background on what rheuma can do in the cervical spine. So I am going to go through a few of the common deformities associated with rheuma in the cervical spine. The first is atlantoaxial subluxation, which is depicted here. There's also subaxial subluxation, which you see here, and vertical subluxation, which is a translation of the dents above the line between the occiput and the hard palate. And these deformities can cause symptoms ranging from pain to paralysis and even in severe cases death in patients with rheuma. So in a previous study, we looked at the prevalence of these deformities in rheuma patients in current days where we manage these patients with medications. And we still see cervical spine deformity in 40% of patients that were well managed for 10 years. So they had low disease activity, but they still ended up having cervical deformity. So we want to research this further, and to do this we have to go through very large quantities of imaging, X-rays, but also MRI and CT. This is very time consuming and also introduces great intra and inter-observer variability. So we wanted to create an automated segmentation algorithm for the vertebral bodies of C1 and C2 in sagittal X-ray images of the cervical spine in patients with rheuma. We used 100 sagittal cervical X-rays for this, and also a smaller subset in some of the experiments. And we started with manual segmentation of the C1 and C2 vertebra. And when we looked at the dice between observers to pick the best segmentation to train the convolutional neural network CNN with. So we ended up with 3 experiments. In the literature, it was very difficult to find an existing model that could make an automated segmentation of the C1 and C2 vertebra because of a lot of overprotection that is present in this area. So you can also see in these labels the deformity that we focused on, which is in between you can see my cursor, but so that's in between the C1 and C2 vertebra, or atlantoaxial subluxation, is not even depicted in the label. So even though the dice score for this image was good, visually it's not very useful. Experiment 2 was a little bit better, but you still see that there is the label is not very fitting, also because of a lot of overprojection. So the experiment that was most promising was the one where we made a segmentation of the atlantoaxial subluxation itself. So we looked at the anterior atlantodental interval, and that is what we got from here. So that's had a lower dice score, as you can see in this overview, but the visual comparison for this one was a lot better. So this model is obviously not optimal yet, and we want to continue optimizing this. And also make it so that it can classify atlantoaxial subluxation for us. So this would lead to a lot less time consuming going through the radiology and then making more steps in treating rheuma patients. Thank you. Yes.
What is the rationale behind the choice of just the satchel as opposed to?
In this case, mostly the availability of data. So a lot of these patients had X-rays taken in the context of a randomized trial that was started in the year 2000. So they were followed for a long time. So they started with the easiest available image, which was a sagittal X-ray. So we used those. But we're definitely also planning on using MRIs and CTs in the future to have more data as well.